have been working on this problem of the shift from acute to community over a number of projects over a couple of years now, and so was asked to put together this kind of workshop session about the challenges of the shift from acute to community. So the way that I've tried to envisage this, I've said it's tools and models to support strategic planning, and I've got a kind of generic workshop picture here. You'll have attended maybe a couple of the sessions that talk about some of the demand modelling that the strategy unit has been doing, or some of the specific tools that we've got that help with strategic planning, or that help with consideration of the care shift. But I thought it might be useful to run a session that looked a little bit behind the scenes in what types of things have we been developing that might help you if you're trying to manage that challenge in your own place or understanding in your own work. And so telling a bit about what we've done, but also sharing some of the places that we've gone to find the data that we need, or that we have used in our modelling and our understanding of this. Some key resources or tools or studies that we think are useful. I'm by no means going to give an exhaustive list, and in some instances I'm going to point to some products that colleagues from our evidence team have pulled together, which kind of are much more comprehensive. But I think that I'm just trying to give an overview of the way that we've started to think about this, and how, in the hope that that's something that's useful for you as well. Please do ask questions in the chat. I will try and keep an eye on that, and there'll be an opportunity for Q&A at the end. There are quite a lot of links in the presentation, and I will drop all of those into the chat at the end, but we'll also make a document for people to access when they get to the end. Claire, you've got your hand up. I wonder if you can... you seem muted to me. I wonder if you can... Okay, I'm going to go ahead, Claire, when you have... and if there is a question, then feel free to interrupt me. So, the way I have set out the presentation today is firstly thinking about the problem, secondly thinking about the options, and thirdly thinking about implementation. There's probably a fourth stage here, which is monitoring and evaluation, but we've got 35 minutes, so I thought I would try and keep it a little bit more succinct, and we can come to that another time. And as we start with the problem, what I want to do is to try and ask, it's a workshop, you've got to do a little bit of work. I want people to have a little think about how they consider this problem of the shift from acute to community. What do you think the rationale is? And borrowing the questions that we used in our logic model workshops for the new for the NHIP, the Implementation Programme of Neighbourhood Health, and the Frailty Collaborative work we've been doing within HSE, can you answer these questions? Why are we trying to do this? What's the problem we're trying to solve? What would happen if we did nothing? What do you expect to change because of delivering this change? And on what evidence are you basing these expectations? There's utterly no judgment in here. I just am interested in seeing whether we all think of this in the same way, or how people are approaching it. So I'm going to shut up and give you 3 minutes, and I'd be really grateful if you could bravely put it in the chat. I could probably do some lounge music, but I'll refrain from singing that. The countdown timer is about to go off. You've got 30 more seconds. Thank you for those who've already put something in. Great. Well, thank you very much for adding those elements in the chat. If you have a look through, you can see that there is quite a lot of agreement, I think, in relation to the piece about reducing the pressure on acutes. And there's varying different ways then of looking at patient outcomes, increased focus on prevention, why it's better overall, the overall view of taking a systems perspective, care closer to home. So there's quite a lot of concepts kind of all captured together in this idea of the shift from acute to community. And I do think that it has a slightly different focus depending on where in the system your perspective comes from. When we've looked at this problem, we've looked to a number of sources. The first one, I think, is the place where most people would be looking. Obviously, there's been a lot of evidence before this, but I think we were quite impressed by the Darcy review and felt that it was a really helpful and insightful piece of work. And he talks about the need for the left shift, but also talks about the challenge that the left shift could in fact be characterised as the right drift. And I think that there's some interesting detailed explanations within there. But we also went to try and understand that idea of the shift a little bit better, had a look at some financial analysis that had been done, particularly work that we've done with the Health Foundation, this bigger picture work, which tries to unpick some of the reasons why that right drift has been happening as opposed to the left shift, which has been a key policy ambition for a lot of time. And you might have seen this in other presentations that have been happening. But it's worth noting that there are a number of factors that are obviously influencing growth in demand. And you can see that elective procedures have grown way more than other types of services, and that those growth factors aren't really linked to demographics. They're due to other factors, which we would hypothesize being things like technology or new drugs, products and tools that can be brought in along with NICE guidance, etc. So we did an additional piece of work, and this is not a full published review, but I've given a link to where you can read a little bit more about it, and which kind of outlines some of the reasons why we think that the left shift has been quite difficult, and the right shift has been happening instead. And you can see some of the reasons here about commissioning attention, political and policy attention, the visibility of data and evidence in spaces that are outside the acute hospital, workforce capacity and capital resources going in that direction. And we also talk about how difficult it is. There's a national policy context which has made it difficult to create hospitable conditions for the left shift, in particular resource allocations tending towards hospital-based care, and the difficulty for community services or primary care to present a strong gravitational pull. Part that's to do with the availability of evidence and data in those spaces. So you can read a bit more about that in the link to the blog that I've given there. Then we've got the do nothing. I think somebody in the chat was talking about, we were talking about the pressure on acute and what happens if we don't relieve that pressure on acute. Well, we've done some analysis using our new hospitals demand and capacity model, which is written up in the missing element in shifting care piece of work that's stated here. We think that if things carry on in the way that they are carrying on, a steady state, without significant changes in service patterns and without achieving left shift, hospital activity will grow in a really significant way, around 40% by the time we get to 34, 35. So you can see a bit of detail in that paper about those assumptions. When considering this locally or nationally, or considering what factors are going to be affecting the ability to left shift, the pressures that are happening in demand is a really important piece of understanding. And I think that this diagram of ways of thinking about demand that was developed through the NHP model is quite a useful reference point to consider whether you're taking into account all of the factors that you should be when you're considering growth in demand, both in acute and in community. You can see, and in primary care as well, you can see some of these factors playing out. So not many of these are captured in the new hospitals demand and capacity model that we're using, and we're not just using it in NHP now. We're using it more broadly, but you can see it can be used as a useful conceptual frame. So I've given a link to this too. And in that work, you might also have seen this elsewhere. We have concluded when we break down the demand projections for the future that there is an opportunity to avoid acute demand. So although the evidence is quite difficult, what we did do was look backwards at the trends in care that have happened in the acute between 2013 and 2019. And this bottom line here is what we would expect if it had been growing according to demographic growth, whereas we characterized a lot of the hospital activity, so things that we think don't need to necessarily happen in hospital, and those things have really, really grown. So that trend, the fact that not all of these types of activity were happening in hospital previously, gives us the hope that it might be possible to shift this, and that the volumes of care that might be avoided are not insignificant. So this is from a publication that is in review for the BMJ, but I'll also link to other places where you can see more about it. So I'll share at the end some of these different pieces of work, but there's demand modelling, there's shifting care, the work that we've done to project community demand, which you can have a look at. There's a tool for looking at healthcare rising demand in the acute and in community one, which we're publishing very shortly. There's the blog that I talked about, also information about waiting lists and what we think is going to happen to productivity and what effect we think that social care is having in this space, and ideas of failure demand. So quite a few, you're essentially getting yourself a reading list and some things to do as a result of this workshop. So that's how we're seeing the problem. I'm going to just check in on the chat. I'm going to pick up that question about activity avoidance. So the idea of activity avoidance here is that it differs, but in relation to a lot of the work that we've done here, it's about types of activity that have been characterised in the acute where we think that the care could be delivered elsewhere or could be prevented, and therefore an admission to hospital is avoided. And so we've kind of categorised and grouped that up, for example, for frailty or for end-of-life care or for some ambulatory care sensitive conditions. I don't know if there's any other key questions in there. Yeah, some useful reflections, but I'm aware of time, so I'm going to crack on. So the next thing is about selecting the options. If we know that that care and that the left shift has been an ambition for a really long time, and we know that there is an opportunity to make that difference, how do you select what action needs to be taken in order to achieve that care? So the way that we've started thinking about this locally in the strategy unit is trying to work out what types of activity we think can be shifted or avoided, trying to work out which patients that might be. So this comes to the description of avoided admissions that we talked about a moment ago, and also trying to see what we can find in the evidence about the types of interventions, models of care, or ways of working that would make a difference. And when we've done work with systems and when we've done work in our analysis, we seem to find that there are two main cohorts that come up time and time again. One is frailty in older people, partly because those emergency admissions in general terms have dominated to a large extent by the frailty cohort. There's a lot of people with older people with frailty using who are admitted to hospital where we think it might be avoidable. And in those instances, there is opportunity for benefit to the patient because we know that there are hospital-based harms and often people want to be at home. And so that has that overlap between benefit for the patient and a benefit for the system and for the funding. And then particularly within the within NHIP program, the Neighbourhood Health Implementation Program, there's a focus on multiple long-term conditions. And the logic there is that increasingly people are getting older, they're getting multiple conditions. We treat them in individual pathways for the particular conditions instead of seeing the individual patient as a whole and understanding their general needs and how to meet those in a kind of holistic way. And the things that those two things have in common, our analysis does agree that those are, in general terms, key places for focus in this area and key places where the volumes are high enough that it might have an impact on acute, and the patient need and benefit to the patient aligns with that ambition. But both of these things are characterized by complex patients, patients with multiple conditions, patients where individual interventions or individual specific drugs or very easily testable things are not what is looked after, what a quality of care increase is going to be, and what will provide prevention. So whilst you can choose the cohort, it becomes quite difficult to choose the specific interventions. But when it does come to choosing a cohort, this is the work that we've done for when we did the national projections for the amount of care that needs to shift. And we have a couple of assumptions in here, which you can read more about in the paper. But in general, this kind of tries to scale the amount of activity that we think could be potentially shiftable or avoidable within hospitals for bed days. And you can see that frailty and ambulatory care sensitive conditions, as well as emergency readmissions, come really high in this. So if you are trying to kind of choose between different types of patients or different approaches, this might be useful information for you. Similarly, it's important to note that not all of the types of activity that we're talking about here are equally avoidable. Some things are going to take a long time for prevention to play through. Some things are, it's going to be quite difficult to, not all of the activity could shift. It might have a marginal effect. So in this paper, Shifting Care from Hospital to Community, we've done some work looking at those particular types of cohorts that we've identified and getting expert views on how much of that activity we think might be shiftable. So there's a reference there for you for this as well. Something, a kind of a first dip into some information that might be locally useful here is this idea of opportunity by these types of mitigable activity that I've been talking about here. So there's a tool which we've published called Shifting Care from Hospital to Community, Where to Start. And some of you may have seen Sarah and Anya talking about this earlier at HACA. But what this does is try to give the number of, it looks at variation, it looks at the amounts of activity that are being used for patients in hospital where we think it might be avoidable, and gives you that information on a local basis by ICB, by provider, by local authority. We've got new tools coming on to help with that and to take that a little bit further. But that's something that I would point you towards if you're working in a local system or an ICB. It's a good way of going in and trying to see how you compare to the rest of the country and where your opportunities might be. I'm going to refer a little now to some of the evidence work that we did for the frailty programme. So I said before, it's sometimes hard to know what to back in terms of interventions. And we talked about the fact that the patients that are likely to benefit most from this and who are likely to have the greatest impact tend to be complex. And when we've worked with the NHS England team on frailty, they had some quite clear ideas about things that they thought would help, including comprehensive geriatric assessments, medications review, community-based end-of-life care, virtual wards or hospital at home. And so I think that and we looked at whether we could find systematic reviews that provided kind of concrete evidence that these would avoid hospital admission or reduce length of stay or avoid readmissions. And in some instances, we see some really positive news stories here, and there is some underlying there's an underlying paper that's as yet unpublished to go behind this that synthesizes everything. But I think the thing that I took away from this is also that often we see that results are unclear or not reported in relation to some specific the evidence picture is more mixed than you would want it to be in relation to this. So, and I think that there's a number of reasons for that it's important to note that in this instance, or in relation to these complex cases, the absence of evidence doesn't mean that these things don't work. We often see really, really strong evidence that these things are great for patients and really do work. The question is whether we can establish a really clear causal link between this activity happening and a reduction in hospital admissions. So some of the reasons for that are also in an unpublished review that we're hoping to put out. And so our evidence colleagues pulled together a range of information, but some of the things I want to highlight here are the fact that the evidence base is patchy. We see less work going on in these preventative activities, in these workforce-based ones, so there isn't as much information in the first place, and often evaluations are done quite quickly, and so there isn't time for impact where we do see those things being evaluated. There's a point here about knowledge inequity and insights from patients, carers and healthcare workers not necessarily appearing all the way through in the way that we would want, and so some gaps in terms of the needs of patients being really clear. Some limited transferability, so often these interventions and models aren't described in a great deal of detail, but there's also a lot of difference in the way that systems are set up locally, and the context is really, really important. So it becomes quite difficult to know that what works in Sheffield might work in Newcastle, for example. And then I almost never do a presentation without talking about complexity because I'm annoying like that, but I think it's really useful to recognise that complexity really does play a part here. And so there are questions of interactions, changes in context, the system kind of fighting back when you see change introduced and things happening over time, which means that it just becomes more difficult to get to clear causality, and all the more important to test what you're doing as you go along and to check, to have kind of feedback loops in your system where you're trying to bring change about. And another piece of evidence that we're looking to put out, and this one is going to be coming out through the new hospital. I keep saying new hospitals. I'm sorry, through the NHIP program in the coming weeks. A look at why integrated care, which is one of the ways in which lots of places are trying to deal with this problem, and INTs in particular are a core tenet of the new neighbourhoods policies. But often the results of the evaluations that we see vary for reasons that are kind of on the screen here: flawed design, problems with context, implementation challenges, unintended consequences, and elements like that. So within this, I can share some guidance, some of the slides, some of the pieces of evidence with you, but I think that what it's worth noting is not that a shift from acute community isn't the right thing to do. It certainly seems to be that is for the benefit of patients and for the system as a whole. But the assumption that it's quite easy to pick exactly how to do that from the evidence base in the way that we might in a more medical model in an acute space is something that is a little bit harder. What we would point you to is some work that we've done as well on end-of-life care, which is one of the places in which the evidence does seem to be quite a bit stronger. We've been doing some modelling work specifically on kidney disease and the effect of primary care on renal patients, and that's some modelling that is the first stage is released and the second stage is coming out, and increasingly the work that we're doing through neighbourhood health will kind of, I think, be monitoring this and looking at the ways in which people are trying to work in a neighbourhood way to achieve these aims. And we're participating in some evaluative activities there, and we'll keep you posted. And finally, I will stop talking soon and come for more questions. There's some questions of implementation. So the way that we've thought about this is trying to think about what needs to happen to enable this shift. What are the key enablers and barriers? How can we tell if we're successful and avoid unintended consequences? So here I'm showing there's a evidence briefing on what neighbourhood working is that colleagues in the unit have done. And here they're kind of showing some of the key 7 domains of effective integrated neighbourhood models, which I think that people find useful. You can see in this as well, there's an awful lot of work done by think tanks that's really, really beneficial in this space. And there's a couple of evidence reviews that we've put in that help you navigate the advice that's coming through those different organisations. And another key piece from that same publication is about key enablers to neighbourhood working from a range of sources. And it's worth noting how many of these are relational and linked to vision, culture and leadership, working together, as opposed to, like I said, a specific drug or intervention. IT and information sharing is really key, and it's a challenge that we know that lots of places are dealing with. But I think workforce and funding resources are one of the things that we found most difficult to get our heads around and to find evidence of the data when it comes to modelling. So if you look at the work that we've done to project what we think the future of community services might be and how you can turn that left shift opportunity into community or primary care money, the best evidence that we've been able to find is old. There's a really detailed monitor review, which I'm putting up the details of here, Moving Healthcare Closer to Home. And it is really detailed. It considers things like numbers needed to treat. It considers things like implementation costs. And it does conclude that in the end, community care is likely to be cheaper than acute. But it does conclude that that is going to take a while to be achieved. And over a 5-year time period requires investment, double running, and might work out essentially cost neutral. And that's not a conclusion that I think will be welcome to many. And I think that trying to fill the gap between whether this is still true or whether there are issues with this piece of work or how we might understand this better is something that in the strategy unit we're really interested in and have been looking to work on a little bit more. Another thing that I think is really useful to bear in mind here is that I really like Rachel Meacock's work in this area, and she is looking at the community services in particular, and she's noting that there's a real difference between micro and macro effect level effects in healthcare. So what we're seeing in the data over and over again is that lots of the interventions or the ways of working or the community and primary care ways that people are services that see a real benefit at a patient level. But when you try and recreate that in population level data, particularly when it comes to hospitalization, it's really, really difficult to do that. So simultaneously, the data shows that community services halve the risk of hospitalization and that community services have no impact on hospitalization. And she talks about some of the ways in which she thinks that this might be understood. One, she's managed to eliminate a number of theories, but one is about the differences between services and how they might be kind of cancelling each other out. And I think it's worth noting at this point that often the configuration of services in social care, primary and community has evolved over time and not been designed specifically to work together in the way that might be most efficient. And the other thing is about release capacity being filled by other patients. So in essence, the kind of the hospital system fighting back because if it's under a lot of pressure and one patient doesn't go in, then there's maybe another patient who's there to take their place. So I'd encourage you to have a look at that work and to monitor it as she works forward and reaches her conclusions. So we're doing more things on this to try and fill in these gaps in evidence, or these challenges in the ways of thinking about things. There's more evidence products. We're working with the National Neighbourhood Health Implementation Programme and NHSE Communities on Frailty, and generating and building some tools for systems, including a new version of that Care Shift Opportunity Explorer, where you can look at the variation locally, some tracking tools to see whether or not how things are changing in systems, some simple models that allow you to estimate what the change might be and how that, and therefore implications of how that might be funded. Some positive deviance that looks at who's been successful in this and what the characteristics of their work might be. Some descriptive community demand model using community services data sets and linking it to patient pathways and to acute avoidance in a way that we think is going to be helpful. And that also links to trying to understand how you convert avoided activity to replacing cost savings, as well as some pieces of research about more about the different elements that I've talked about there. Now, I know that I've talked in a lot of detail, and I know that if you haven't been working in this space for a long time, I might have lost some people along the way, but I'm hoping that that the description of workshop and the idea that you might get something from this that you can kind of go away and look at, and that will make your life a little bit easier going forward or enhance the way that you can look at this, is what we've achieved. But we'll see from the comments or from Q&A. So I'm going to have a look at what's being said in the chat, but if you have any questions for me, then please put your hand up and we can have a conversation about it.
Hi Jenny. Hi everyone. Sorry, I'm jumping in here. It was just to give Jenny a little breather. I am down to host the session, but due to kind of jumping up from another workshop, I couldn't get here in time to begin with. But yes, we've got a few minutes now for a bit of Q&A. Rather than people raising hands, because I think sometimes it's a little bit tricky, people coming off and coming and unmuting, so sometimes in terms of lag with the internet. I think it's easy if people kind of post their questions in the chat, and we'll try and pick those up as best we can. So please do. I don't know if we wanted to frame a little more about the questions there, but yeah, we can look into kind of exploring what people might think about why those patient level effects aren't always coming through to a system level, different things. But I can see a question in the chat, Jenny, from Chandan, asking about those multimorbidity aspect. So considering there can be many different combinations of long-term conditions to build new delivery models, or has anyone at the strategy unit looked at this and thinking about the most common combinations of LTCs?
So I think there's some national work that's gone on in relation to long-term conditions that I think is really quite useful here. I'm going to stop sharing my screen, and I think, oh, that's not the same. That's just getting rid of my face. That I think is quite useful. I think we can build on that. So basically, NHSE work on long-term conditions has identified the idea of some gateway conditions. So and looks at the combination of conditions that are in existence, and concludes also, we know that long-term conditions are linked to deprivation, and it also concludes that many of the long-term conditions have avoidable characteristics, have links to activity or to smoking or to obesity. And so there's a sense that prevention activity can really make a difference there. That work has started to look at what they're calling kind of gateway conditions, so which conditions people are likely to develop first, and then what tends to happen in terms of mobility afterwards. And I think that the way that we're likely to take that forward is by continuing to consider how we might kind of subcategorize or understand in combination between the evidence and the activity that we can identify in the hospital, how we can start to break that down into patient groups that become more meaningful when it comes to planning at a local level, so that you can kind of think about a pathway in a way that allows you to recognise that multimorbidity, but identify those patients in the best way possible. But we're not looking at it very specifically at this point in time. The slides, so yeah, I can see that question there. Yes, A, the slides will be shared, and B, I'll give you my kind of reading list from the slides, Jennifer. So that's kind of the ambition, and I hope that, yes, as I say, I was galloping through quite a lot there, but hopefully by using the slides and the links that I've sent, you will find that you can pick out the things that you find most interesting. There's another message there. Key examples that we've seen evidence that successfully have transferred from acute to community. Yes, so frailties one. We do see some evidence from vanguards that some of those did work, not necessarily at the scale and pace that people wanted. And I think, like I say, the geriatric assessment in frailty, I think, gives an indication that some of those collaborative and planning and coordinative pieces of work might be things that are successful. Colleagues are kind of looking, there are, which I haven't mentioned so much, some evidence maps that has been mapping work that has been done, and I think we need to work out what we're going to do next with that can help point out the things that we think are kind of best bets from the evidence. Okay, and then there's a question here about return on investment for new schemes. I think it's really challenging. I think the evaluation, we have some guides, evidence guide, some evaluation guides and measurement guides coming out through the Neighbourhood Health Implementation Programme, and I think that might help. I think that in terms of specific economic evaluation and return on investment, part of the challenge is how quickly you might be seeing that effect, and how to consider that in the round. So I think I can point you towards some places in which we're trying to work out where that advice might come from and what best modelling there is, but I don't think that that's in any way settled. I think it's quite a challenging thing to be doing. It's also necessary, and I think one of the things that we're developing to try and deal with the Rachel Meacock point that I was talking about is some national analysis that will tell you whether or not your threshold, your case mix adjusted for providers at A&E is changing. So if you are managing to avoid admissions for some cohorts at the acute, so you're doing a really great job with frailty, but actually different patients with a lower level of acuity are now kind of coming in and using up those beds, you'll have a way of understanding that and be able to see that. So I think that there's a combination of monitoring a number of different factors that is going to be useful. I also think, I said a bit about complexity earlier on, but the unintended consequences piece is really important. One of the things I've put into the slide is about GP access and the different attempts that have been made to improve GP access. And what you can see there is that often the things that have been tried haven't had the intended effect, and sometimes they've had the opposite effect by mistake. So, for example, disrupting continuity of care with GPs then means that actually, patients can't get to see their GP, and then the demand from those patients increase. So I think that it's really, and there's some similar thinking about what your level of diagnostics is and whether or not we've done some work that shows that if you kind of rapidly increase the amount of diagnostics available, you kind of disrupt the flow of patients, and you might end up with more healthy people in the system that can cause you problems in terms of meeting the needs of the people, meeting the highest needs. I think that is, there are some really interesting things to do about trying to make sure that you're monitoring unintended consequences and watching what you're doing, and looking at the data in the best way that you can, not just for what you're trying to look at, but the related elements. And gateway pathways, I will find out whether or not that NHSE work is nationally published. I know that Manal Bakai has been referencing some of it in the presentations that she has used. So if I can't get the full published data set, I can at least stick a slide or two into the resources that we make available after the workshop. I feel like we're at time, so I probably should let go. Top 3 tips. Oh, that's a good idea. Okay, so I think tip number 1, when you're thinking about how to make changes, don't forget that demographic changes and increase in demand is going on in the background anyway. So you need to plan for both the effect of demographic change and the growth that's going to come from that, and the care shift when you're doing that planning. That's number 1. Number 2, try to make sure that you shift your mindset. If I may be preaching to the converted, but this is a complex change, and so use the information that is available to you, but including experiential knowledge, the knowledge of how your systems are set up, the ways that things interact with each other. So try and think in terms of restructure of services and how things might fit together, instead of a simplistic RCT model of, right, we need to do this and we need to drop it in as a kind of an add-on. We're really talking about system change from primary and community care perspective. And the third thing would be, I think that frailty and multiple long-term conditions are probably the opportunities that are the biggest opportunities, and that would make the most difference on acute if you manage to play those things through, and that there are quite a lot of resources that you can use to try and get a sense of what the scale of that difference might be, and so back those cohorts, and then talk locally, including to patients and to clinicians, to try and work out what might be the way to go in order to improve that care and to avoid the acute activity. That would be my 3.